So, good afternoon, friends. I welcome you all in a All Gujarat Ophthalmological Society symposium. I hope all the speakers are present here. Dr. Mayuri Khamar, Dr. Alay Banker, Dr. Priya, Dr. Sandeep Arora, Dr. Mohak, Dr. Sahil, Dr. Parth, and Dr. Aditya. Now, shall we start with Dr. Alay? Alay. Alay. Alay, start कर दियो.
5 મિનિટ રહીને કરીએ ને.
ના પછી આવે 5 મિનિટ શું કરવા ટાઈમ ટુ ટાઈમ પતે જ છે હા
અરે ગધેડા કે બધું ચાલુ થઈ ગયું આવું શું કરે છે તારો એને મજા નથી આવતી હા હા એટલે સીધો છે ને પેલો એનું હોય ને એમાં ગેટના એન્ડ પર છે ટ્રેડનો એન્ડ છે ને ફટાફટ ચાલ મૂકી દઉં લોકેશન મોકલું
ये पेन रख पेन
और गालियाँ देनी स्विच को
कौन
ओके હા મયુરી મોડું કેમ આવ્યું આ બીજા 10 જણને લીધો તો આવવાનો
મયુરબેન તમારું નામ પહેલું છે મેડમ યુ આર ધ ફર્સ્ટ સ્પીકર
મયુરીબેન આવું ચાલે
હા તમારું આઈ ઇન્વાઇટેડ યુ ફર્સ્ટ
હા જો આ બીજા આયા એટલે ગ્લોકોમાના બીજા આયા
सारा कैसे लाइट नहीं ग्लेर ग्लेर आ रहा है
શાંતિ ઓછા આપણા થોડા
As we all know, Dr. Mayuri Madam is a well-known glaucoma national faculty from Gujarat. She will speak on bleb assessment in vivo. Dr. Mayuri Ben.
Thank you, Dr. Rana and Gujarat Ophthalmic Society for giving me this opportunity. The trabeculectomy is still the most effective filtering surgery, even though more and more surgical options like MIGS is coming up. Long-term data has shown that the efficiency of the trabeculectomy is persisted even after 15 years in 67% of the patients. The follow-up care of these patients, the ophthalmologists focus mainly on the bleb as the functional part of the trabeculectomy. Various classifications are available which describes the clinical morphological features of the bleb and which can assist physician to take the decision. But the clinical evaluation of this patient can be challenging at times. This graph is showing you that in initial first 2 to 3 months, there is a chance of failure, and eventually after 6 months, it becomes stabilized. So whatever is the failure, it happens in the early phase. The Murphy classification gives you the bleb morphology, which is an important indicator of the bleb function. It calculates the area of the bleb, height of the bleb, and vascularity of the bleb. Indiana bleb morphological classification also includes the Seidel sign. There is a leaky bleb or no leak. And Mays bleb appearance grading system also include the transparency of the bleb structure. So imaging the trabeculectomy bleb using the intersegment OCT is a promising tool to image this bleb, and it was able to demonstrate the features of the bleb morphology which are not visible with the slit lamp. So the assessment of filtering bleb function with AIOS-OCT is a useful tool to evaluate the filtering bleb functions. This is a classic example of the cut section of the AIOS2025 generated bleb area. You can see here the subconjunctival fluid space. There is a suprascleral fluid space, a root beneath the bleb, sclerostomy opening, iridectomy, and bleb wall. Ideal bleb should have a vascularity similar to the surrounding conjunctiva. It should have a numerous microcyst, diffuse bleb, and moderated elevation of the bleb. And these on the slit lamp examination is shown here, but AIOS2025 gives better evaluation of all these features. Similar looking blebs can have a different internal morphology as shown here. This bleb is showing you the spongy look, while this has a large anoic space with a thin layer here, and this is a diffuse thick wall bleb with a large cavity. At times, the clinical appearance could be deceptive. When you look at this bleb, which is avascular, mildly elevated bleb, but when we did the AIOS2025, you can see the thick wall bleb with one single cavity, and this may not be a good functioning bleb. Cause of bleb failure is usually vascularization and fibroplasia at subconjunctival and suprascleral space. Rarely it could be obstruction of the internal ostium with the iris or ciliary processes. So coming back to the first graph that I have shown you, can we predict the early failure? Can we recognize it early so that we can prevent the failure and we can manage this bleb better in the early phase? So the most important step in the management of failing bleb is to recognize its presence. So with this aim, we undertook a study to correlate morphological features of the bleb on AIOS2025 at 1 month with the bleb functionality at the 6 months. So post-operatively, IOP was taken and blebs were photographed, and AIOS2025 was done. 2 radial and vertical sections were taken at the most elevated area of the bleb. The bleb wall reflectivity was divided either in the uniform reflectivity, which is hyperreflective, which is suggestive of dense white area as shown here, and the multiple reflectivity with multiple tiny cavities of aqueous drainage. Multiform bleb wall reflectivity again was divided into multiple internal layers, subconjunctival separation, and the microcystic areas, which could be an ideal bleb for the function and success. The root beneath the scleral flap was defined in all these cases. So at the end of our study, we concluded that various patterns were seen: microcyst with the multiple layer, or microcyst with the subconjunctival separation, only microcyst, and uniform bleb. So uniform bleb has a more risk of the failure, and the 100% success was seen with the microcyst and subconjunctival separation. So we can predict the long-term success at 1 month by doing this test. Bleb wall with the multiple reflectivity shows increased chance of success, and bleb pattern with the multiple internal layers and microcyst is ideal for the success of functioning filtering bleb at 6 months. One more Japanese study has done. Our findings are matching with this study, but they also had a calculation of the width of internal filtration site. 2 eyes bleb may not have a similar pattern. They may behave differently. This is a case post-op day 10 showing the flat bleb and IOP showing the rising 14 millimeter of mercury. So should we remove the releasable suture in such case? Yes, we did release. This is the homogeneous area showing you the flat bleb, dense wall thickness. Post-release, immediately you can see the elevation with the multiple areas of the aqueous, microcyst, and the conjunctival separation. So mitomycin used with the trabeculectomy can have a dreaded complication. So the safer option was introduced in the form of biodegradable implant, which leaves behind its negative copy at the end of 6 months. So the absorption of this material creates an aqueous pocket subconjunctivally with a microcystic area away from it. And there is a complete absorption is seen associated with the shrinkage of the bleb. Is it okay? Should I continue? So this is the anoic area. On day 1, you can see the homogeneous implant. At the 3 months, you can see the aqueous pockets are coming up. Aqueous areas is seen, and at the end of 12 months, there is a total shrinkage of the implant here and good cystic spaces on the suprascleral region with a small and microcystic space on the side. Expression were used initially, and they were showing you the position of the lens and the good bleb function. Tenon cyst is shown here, and after needling, we can see the flattening of the cyst, and at the end of 6 months, the thick wall bleb with a large cystic space. You can also use this technology to look at the positioning of the tube that has been implanted here, no touch to the cornea, and good pathway. So implication is AIOS can be used to identify the internal structure of the bleb, thereby providing the better understanding of the bleb morphology. It can predict the success at very early space, post-operative period, and there is a scope of early intervention in the form of enhancement of the steroid or needling, use of 5FU or MMC, and you can release the suture in time. So limitation of this technology is vascularity of the bleb, and leaking cannot be judged with this technology and difficult in the children. So it is a useful modality for evaluating the natural history of the implants that you have used, or it can predict the long-term success. Thank you.
Hello. Thank you, Mayur-ben. I would request Dr. Alay Banker. He will be talking on ROP project in Gujarat.
Thank you, sir, and I would like to thank Gujarat Ophthalmic Society for giving this opportunity. The ROP Gujarat project was started way back in 2012 as a partnership with the NRHM government of Gujarat and Narayan Netralaya. And initially, they funded us with the RedCam camera. Unfortunately, in 3 years' time, they stopped giving us funding. So we were left without any funds. And that is how we started this self-sustaining ROP screening project. I run the entire project on a total charitable basis. I do not take any charges. And the main expense of a clinician was thus devoid. We got some donations to buy the Forus camera, which is manufactured in India. And then we went on to get the second Forus camera with the fluorescent angiography, which were both donated to us. And as a ROP capital cost, we also got a van, which was donated to us by one of the donors. And that is how we started the entire project. So this is the van where we take the camera, and this is the Forus camera. And this is how we do. The entire team takes the camera. This is in the form of a mobile van. Every day we start our screening, and it's a fixed schedule screening in different NICUs. The camera is put on the back of the van, and we go to all the public sector and the private NICUs in and around Gujarat, covering almost 5 districts, right up to Mehsana, Patan, Palanpur, Dharpur, Himmatnagar. And once the team reaches the base hospital, you know what's happening. Something wrong. No audio. आवाज है, but you can stop it. Anyway, I was just showing how we do the screening. It was one of the government hospitals where we go in a general ward. There is no space for doing the screening. Also, the mothers are all lined up in the pediatric ward itself with their babies sitting in their laps. And these are all the districts that we are covering. It is a fixed schedule every day. And these are a few photographs where we are doing the screening, and we are given a very small room in one corner and just in a small space in a government hospital. And this is exactly how we work. And you can see the lobby onto your down and right. This is one of the hospitals. There is no space in the hospital. The mothers are all lined up in the lobby of the hospitals with the babies in their lap, waiting to be dilated and in a very crowded room. Again, a few of the government hospitals, and you can see how in such a state we do the screening. The smallest baby that we have screened is 480 grams, and the smallest is 24 weeks. This is the baby that we have done, and we also go into the NICU and do the screening. This is then linked on to the phone where we do the telemedicine screening, which can be done even on the iPhone, and a detailed record is given to all the mothers with all the findings as well as the appointment for the next follow-up. All the treatments are done by me personally, totally free of cost to all public hospitals, and we charge a very minimal amount to all the private NICUs. Following the injections, counseling is also done by a neonatologist as regards breastfeeding, kangaroo mother care, and taking care of the nutritional aspects of the baby, which is very, very important in the development of the retina of ROP babies. This is just a brief, rough report. This is the actual audited expense report of the entire program. And if you see over the few years, roughly the average expense comes to about 25 lakhs. So it's about 2.5 lakhs, and we've screened more than 51,000 babies, and we have treated almost 1,000 babies so far. So you can imagine the cost that incurs to us as regards the salary of the, the entire team, the operational expenses, the petrol expenses. We go as far as 200 kilometers, the car expenses, the stationery, and the summary of the charges which are given to the entire team. However, what I have done is I've taken a pledge 10 years back, and I devote and donate all the private income that I get from my private NICUs directly into the project. And these are rough cases. These are the 2 private NICUs which I usually do. And whatever income comes is directly donated to the Health and Care Foundation directly into the project. And it is about 45 to 48 lakhs so far. We were also very fortunate that we got donations from former President Abdul Kalam and even Sunita Williams, who had visited us way back, and she also donated a big amount. So we feel that any ROP project could be self-sustainable once you explain how important it is. Yourself, you will find donors coming to us, and till today, as of today, I still have 3 donors waiting to donate huge amounts, and we are expanding our donations, and we are developing 2 more teams, which will further go into Saurashtra. We have already had 1 more team now in Bhuj, where we have started screening in Bhuj and Kutch area. And this is entirely based on donations. So I don't think that we necessarily have to depend on the government machinery always to fund such health programs. I think if you have motivated team, it is always possible, and you'll always have donors who are willing to donate. So I would like to thank all my babies and their parents, and it is very important because without their help, such a huge program cannot last, because ROP is a lifelong disease, and you need lifelong follow-up. And it is the cooperation of the parents that is very much required. And lastly, I would like to thank the Health and Care Foundation, which has given me the platform to do such a noble work. Thank you.
Thank you, Alay, for bringing out such a beautiful
Allah, you are doing
community program.
You are doing the noblest work, and I come forward that if you require any, if your organization require any financial help, I'm there to support it.
Thank you. Sir, I think we just need to spread the word around. That's the biggest
Na
help.
gamme tare, you can depend on me for 5 lakh minimum.
Thank you so much, sir.
Now I invite Dr. Priya Narayan for masterclass iris repair and its outcome. Dr. Priya.
મોં કયો ક્યાં જતો રહ્યો છે?
Good afternoon, ladies and gentlemen. At the outset, I would like to thank all the office bearers of Gujarat Ophthalmic Society for passing on this excellent opportunity to me, and I'm going to talk about the iris repair procedures in this talk. So, let me begin with the iris repair. So basically, iris repair is divided into the pupil-centric method and it's an iris-based centric method. So these are two methods because you have to reconstruct the iris base many times it's a pupil-centric, many times it's a combination of both the procedures that needs to be combined. So the basic requirements are listed here. You need an polypropylene suture, the end opening forceps, scissors, a 27-gauge cannula, the Lester's hook, and the fluid infusion going on in the eye. So let me go ahead with this first case. What you see on the left is the undilated image, and what you see on the right is the post-dilated image of the same patient. History of trauma to this patient. In fact, this patient was almost like 60, 65 years old and had a history of trauma at the age of 5 years. And he had been like this whole life without a surgery. Nobody actually operated upon him because he had a clear lens at that point of time. And now he has come up because now he has a cataract, but he always had photophobia throughout his lifetime. So I go ahead with this surgical video that I did for this patient. So like this is the image of the patient. And what I start ahead with this is like, after dilatation, obviously there is an iris out there into the center. So we need to keep that aside because we first need to go ahead with the cataract surgery procedure in this patient. So going ahead with the normal cataract surgery procedure, the first thing is that you need to place up the iris hooks. I always try to use iris hooks in these cases because, these are all complicated cases and you actually do not know what would be the outcome many times. So you go ahead with the normal cataract surgery procedure in this patient. You have to be very careful with doing the capsular rhexis and everything because you need to have a good rhexis in this patient. And as you see, there is also a lot of fibrosis into the capsule. But having managed to do a good capsular rhexis and a phacoemulsification, after that doing an IA and putting up a 3-piece intraocular lens. I would always choose a 3-piece IOL in these patients, although you can also use a 1-piece. The idea of using a 3-piece IOL is that, if at any point of time, if there is vitreous coming up, so then I would just do a vitrectomy and I would refixate this with the secondary IOL procedure. I would use the same intraocular lens because then I don't have to remove this intraocular lens outside the eye. Anyway, moving ahead with this, you can just see this iris is it's so difficult to manage these kind of irises because it has been in this position for almost 40 years from now on. And there are many techniques of doing an iris repair procedure. So at any point of time, you need to know at least 1 or 2 different methods of doing because many times, something does not work. For example, I'm showing you this video because here I'm trying to do a flange technique for fixing up this iris tissue. And I have actually taken up a 6-0 suture, vicryl suture, and this is the flange procedure that is being done. You create a flange on one side and then you just press it off so that it's a rivet kind of a thing. And then you take this into a 26-gauge needle and then this knot, it actually, the bulb holds it, but it actually slips off in this because this iris tissue is almost giving way. So then I decide to go ahead with a non-appositional iris repair in this patient. So this is again a double arm suture which I'm trying to take this, and this is an inopolypropylene double arm suture. You have to be very careful in, I always say you should be very precise in involving a little bit amount of iris tissue into your suture needle because, if you take too much, you will have keratoconus at the end of the surgery. But anyway, going ahead with this is a double arm suture. And I'm just trying to pull this off, and you can just see how beautifully when you pull both the sutures, that iris tissue in that area, it comes up into its position. So then you have to titrate, and when you tie the knot, you should be very careful of not making it too tight or things like that. And you can do this procedure throughout the area of the iridodialysis. So what happens is now, in case, now that was the iris-based repair. And now what I'm trying to do is a pupil-centric method because you also need to have a center of the you need to have a good pupil in the center because you cannot expose the edge of the optic of the intraocular lens because if you have that, again, your patient is going to have a photophobia. So what I'm trying to do here is the single-pass 4-throw pupilloplasty procedure. This procedure was described 5 to 6 years back, and we actually take 4 throws in this procedure. Once you have that loop out, having taken up 4 throws, you just pull both the suture ends and the loop beautifully slides inside the eye, and then you just take an end opening scissors and then you cut it off. The beauty of this technique is you do not have to do it again. like you do not, it's not like a 3-1-1 kind of a knot. It's just 4 throws and you're almost done with the surgical procedure. So then again, if you have a much more area which is left out for the reconstruction, you can again go ahead and you can close that. So this is how this case actually winded up. And actually, I'm also trying to close. I can even leave it like this, but no, I still want to close this, so I'm trying to go ahead. The second most important thing is you need to be very careful in seeing that how much, your needle should not go through the iris shaft area. Once your needle goes through the iris shaft area, there is no way that, it's going to stay there for very long. Maybe after a few days or something like that, the suture will cut through. It will cut through to the shaft area, and like it will be a failure of the iris repair procedure. So these are some of the important points that need to be taken into consideration while doing this. So this is how this case actually ended up. The patient was very happy, beautiful, because for the first time in his life, he never had photophobia, and he did very well in the post-operative period. So I think I have also put up the pre-op and the post-op image of this patient, and this patient did very well in the post-op thing. So I would just try to emphasize on one of the other techniques, which is the reverse four-throw, which I just described 2 years back into the European Journal. And this is the surgical video which was put up on the Academy site, the American Academy. Now, I'm just trying to showcase how this technique actually works. What you do here is that you take up a nanopolypropylene suture and you enter the iris area from behind. Your needle does not go from front to back. It comes from back to front, and the same thing happens on the other side. The concept of doing a reverse four-throw is not getting the knot into the anterior chamber and getting the knot slip back into the on the posterior surface of the iris. So this procedure is quite similar to doing a single pass, but the only point is that you have a needle coming up from behind and entering the anterior chamber. So this is the railroad which is being done, and then again you pull this out, and then you have a Lester's hook, and then again you take up the 4 throws and you pull the sutures. Now the concept of doing this is that I also call this as an iris stapling procedure, because this looks very beautiful. At the end of the surgery, I will just show you, you will not be even able to recognize where the pupilloplasty has been done in this patient, because actually you don't see anything in the anterior chamber. So that is how this technique actually works in this. So this is the reverse 4-throw pupilloplasty procedure, which I thought I will just highlight, because it is one of the newer techniques which have come up in the pupil repair procedure. So you can just take this. 4 throws are very important. All the 4 throws need to be taken in the same direction. If you forget counting the throws, you can take 1 or 2 throws extra, but it should not be less, because if it is less, the moment you slide it inside, it will just open up. So you will have to redo this procedure all over again. So this is the single pass. This is the reverse 4-throw pupilloplasty procedure. I would just like to show you, you can just see this, how beautifully it slides inside, and the knot actually goes behind into the behind the surface of the iris tissue. So this is, then you can just cut it up with the end opening scissors. You need some special instruments to do this, so that you have a wider access, of these instruments inside the eye. So this is how it actually works. So I'll just like to show you the, maybe that was an anterior segment OCT image which I just missed off. This is the animation which describes the surgical procedure. So this is how the needle comes in from behind to anterior. It comes off in the similar way from the other side. And this is a 26 gauge needle. You need to have end opening forceps too, because then otherwise, other forceps, they do not actually work. And then you just railroad this. So this is how it actually goes through. This is the passage of the suture going ahead. So once you get this thing done, actually you have to be very careful. The iris tissue is a very friable tissue. You need to, once you get a knack of this, it's not very difficult, but yes, it's not that too simple also. So once you get this, this is how it goes, and this is how you cut, and this is how it looks. So this is just a suture track, which I'm just trying to show you. So for a better understanding, this is how the suture track goes, and it comes out. So this is how the iris stapling or the reverse 4-throw technique actually works. And this is the animation. A normal pupilloplasty, you have knots in the anterior chamber. With the reverse 4-throw, you have it behind. These are some of the clinical images of the reverse 4-throw pupilloplasty. You can just see the black arrow on the left, on the top left. You don't see the knot. So I think if my time is over, maybe I can just stop this. Oh, okay, then maybe 1 or 2 minutes extra. So this is the. Okay, let me skip this. I would just show you this. This is the single pass 4-through pupilloplasty procedure. This is exactly opposite of what I showed you. You can see how the needle pierces. In this case, this is a very simple thing to do. You know, you have that needle coming up, it goes in the direction of your throw, and you pierce this with a 26 gauge needle. These days, I have just stopped using a 26 gauge needle. I just have one needle going from here, and then it is just out. So, and you also stopped using the 26 gauge. We use the cannulas, you know, because it actually helps you not to imbibe the corneal fibers into your suture. So that is another important thing for the pupilloplasty procedure to work ahead. So again, 4 throws in the same direction, and you have this pupil thing going in. So 4 throws is the optimal thing. So this is how the technique, it actually derives its name. It's called as a single pass 4-throw pupilloplasty procedure. It's actually very beautiful to see these knots sliding inside, and you really feel good when you have that approximated iris tissue coming up together. So this is how it actually works like. You can keep on doing till you have that iris defect out there. So thank you so much.
Thank you very much, Dr. Priya. It was really a master class of iris repair. Thank you.
Thank you.
Now I will invite Dr. Mohak Shah, Intraoperative Flap Complication Management and Prevention.
First of all, thank you very much to all the office bearers and Dr. Sandeep Arora sir for giving me this opportunity. हो गया? क्या हम नहीं आया sir? Scientific committee chairman is not here. Okay, anyways, back to the topic. So basically, the most common intraoperative flap complications happen because only of these 2 reasons. First is the inadequate poor exposure, and second is the inadequate suction. No, it's not coming. Yeah, अभी आएगा. Blank. दो हॉल में तो चला यार. So first thing is the inadequate poor exposure because of the ये चला ही जा रहा है भैया. I think this wire is loose. देख लो एक बार. लूजर मेरे हिसाब से 100%. वहाँ पे है, वहाँ पे करो. I think Sandeep Arora sir is remembering me very much. Okay, so deep orbit, small eye, narrow palpebral fissure, leading to all the different difficulties in the various steps of the LASIK, which I will be talking about later. And the second most important thing is the inadequate suction. Why it happens? Because of there is a suction loss because of the blocking of this microkeratom assembly due to the debris, drapes, speculum, there's a chemotic conjunctiva. And all this leads to the different type of flap complication like irregular flap, incomplete flap, free flap, buttonhole. Now just quickly see this video. I'll be showing mostly the videos. Here I'm trying to make this is early LASIK days when I was learning. I'm trying to make the flap with the M2 M2 microkeratom with the 130 micron. I have marked the chorea. Now just see, I'm applying the suction ring over here. Just keep it close eye now, just see over. It looks absolutely fine. Just see the downward movement over here. And you can very well see that there is a suction loss, you can see, and this is the only incomplete flap over here. So the flap is not complete, just see this. This is an incomplete flap. So here in this scenario, you cannot go ahead and proceed with the ablation. You have to abort the procedure, but you have to make sure that all the flap margins are properly opposed to prevent any epithelial ingrowth. So what do we do next? So we have to basically wait for at least 3 months. Nowadays, I wait for around 8 weeks for the eye and reflection to stabilize, and we either do the surface ablation or we recut. Another quick video. This is again the older days. Now with this Moria and SBKs, the complications are absolutely almost very negligible. Just see here, this motor is stuck over here. Ideally, it has to still pass this passage, but it is stuck over here. So here I know that my flap is still not complete. It's an incomplete flap. But fortunately, when we lifted the flap, you can see that it is beyond the pupillary margin. So here I got escaped. I reduced optical zone from 6.5 to 6 millimeter, and I was able to go through. So the next thing is the management of this incomplete flap. So if you have an incomplete flap and you have sufficient area or room for the ablation, you can reduce the optical zone from 6.5 to the 6.25, 6 millimeter, but you should not go beyond the 6 millimeter zone. And if you any condition like this is affecting the pupillary area, then you have to abort the procedure. This is another thing which we tried. Here you can see this is the incomplete flap already. You can see this over here. Here in my practice, we only do the 90 micron flaps. That is the reason something goes wrong. And I always have the space to do the deeper cut. So the thing here is to make a flap which is slightly smaller and the deeper. So initial flap was 100 micron. Here I'm making a flap with 130 micron. You just see I'm double confirming the vacuum. So most important thing here is to identify whether the vacuum is properly built up or no. First, you can see on the microkeratom machine, it should be within the range of 120 to 160 millimeter of mercury. Then you lift it up slightly to make sure it doesn't come out easily. And third thing, you ask the patient whether the patient stops seeing the lights. Here you can see how easily I'm able to make this new flap. There is no intersection between the newer tissues and the older tissues, and the rest of the procedure is same like a normal LASIK one. This is how the post-op 2 eddies are seen. This is the older flap margin. This is the newer flap margin. But what is the drawback of this microkeratom recut? Many of the times, the older flap tissues and the newer flap tissues can intersect with each other and result in the silvers of the tissue. Whatever happens, do not try to remove them. Otherwise, patient will end up having the lot of visual difficulties. It is not that the vacuum loss and everything happens only with the microkeratom. Here you can see I'm trying to make the flap. Already there is a vacuum loss over here. I'm trying to make a femtosecond flap. As you saw in the video, it was only half, but that is the beauty of the femtosecond lasers. Here you can resume with the same parameters, with the same settings, and in the same plane. You just have to wait for around 5 to 6 minutes for the bubbles to appear. So I'm again docking it again, and you'll be amazed to see how easily I'm able to lift this flap without any trouble. You just don't feel like something has gone wrong. So that is the advantage of the femtosecond laser. Next is the free flap. Why does it happen, sir? What are the anatomical factors? Most common anatomical factors are the large cornea, flat cornea, high mixed astigmatism. Here you can see my ring size is +2. Here I'm trying to make the SBK 1 use plus 90 micron flap. Here, by mistake, I am selecting the +2 ring. In SBK, suppose 0 will have the maximum hinge, +1 will have a shortened one, and +2 will have a more shortened one. So here, ideally, I should have used the ring of the +1. Just see now what happens. You can see that this is the free flap, and the flap is always here. So just try to see first into this blade keratom assembly where your flap is lying. Just see over here. This is where this is a 360-degree flap. So now how will you treat this case? Whether you will go ahead with the ablation, whether you will not go ahead with the ablation. So what we do, we can easily go ahead with the ablation. This is another free flap which has already happened. Then I started recording. So I'm just putting it aside, making sure the epithelial margin is this side and stromal margin is this side. Even if you don't know which side is the epithelial one and which side is the stromal one, you just scratch it out with the cannula, and the rough side would always be the stromal side, and the epithelial will slightly peel off. So you can just put it aside, do the laser ablation, and align it. If you have marked the cornea very well, nowadays we don't mark the cornea. So as I told you, first is to identify which side is the epithelial, which side is the stromal one. So once you have done that, you just put the flap back, and there will be some areas of some notches or irregularities which you can align with the flap margins and get away. It is not that this free flap happens only with the microkeratome. Again, the femtosecond laser, this is one of the unique case which I encounter. I've already made a flap. I'm trying to lift the flap. This is my earlier intralace days when we had it for the demo. And just see here, I have made a superior hinge and I'm trying to separate it. You'll be amazed to see the patient is absolutely non-cooperative. And my mistake was that I was also anxious. I was not talking to the patient. And suddenly there is a jerky movement while I'm trying to dissect. And oops, there is no longer hinge available right now here. You can see here. So now what to do? But suddenly the idea struck my mind. Here, I have still not yet fully dissected the flap. So I converted my superior hinge into the inferior hinge somehow and completed the ablation. So you have to do it very carefully. You have to make sure. So just like this, I converted from superior to inferior. You can get away. So as I told you, for the free flap, I already discussed large flat corneas and how to prevent. You have to still nowadays, I was not doing it, but after a couple of cases recently, I started again marking those flat corneas like this with these markers. And dreaded complication. Can I just have 1 or 2 minutes more? Okay, so most dreaded complication I'm worried about is the buttonhole. Most commonly it happens because of the reuse of the blades and the poor quality of the blades, and many other times we are overusing the anesthetic eye drops. So nowadays what I'm doing, I'm just only putting the anesthetic eye drops when a patient is on the OT and the same eye which I'm going to operate. If I'm going to operate right eye first, then the right eye, and the left and the left. And again, the steeper corneas, irregular astigmatism plays a huge role. The better they are prevented. So identify the risk factor like I told you, avoid the aggressive use of the anesthetic eye drops, change the blade after every cut, do not reuse them. And that is the advantage I think we have with the femtosecond lasers now, because there is no way you can reuse those packs because your license gets counted. So how does the management? Depends on the location, size, and the type. It's a partial thickness like this, away from the pupillary margin. You can safely go ahead with the ablation. Just put the BCL and wait for the epithelium to heal. But if it is central and partial or full thickness, one cannot go ahead. One has to abort the procedure. Make sure the margins are properly opposed. Push the BCL for 2 to 3 days. Make sure epithelium is properly healed. There is no epithelial ingrowth. It then depends on the further management. Depends whether it is associated with the epithelial ingrowth or no. If no, you can easily go ahead with the PTK with the mitomycin C or PRK with mitomycin C. If the epithelial ingrowth is there, first you have to take care of the epithelial ingrowth by doing the PTK, then you have to combine it with the PRK with the mitomycin. Again, it is not that the microkeratome causes this. Now this is the unique case of the buttonhole, which we call it the vertical gas breakthrough in case of the femtoLASIK. Just see here, I'm trying to, you can just see that the dissection is quite going very well. This laser formation, the bubbles are quite good. Just keep it close eye over here. While it is about to get over, suddenly I don't know what went wrong, and I have this area of the vertical gas breakthrough. Nowadays, with the advanced laser, the incidence of these are quite low, but still, it can happen to anybody. So I knew that in that area, dissection would be very hard. I was not able to dissect with the normal spatula, so I had to use, in this case, the keratome. Just see, I'm trying to separate it with the, crescent blade. And I was able to do it. I got lucky. So I think these are some of the cases. And the idea is to show you that the complications are going to happen. Whatever complications are there written in the books, all of them I have encountered. I think Parimal Uncle has encountered. We all have encountered. But thing is, if you manage well, you can come out with the flying colors. That is a take-home message. Thank you very much.
I would like to invite Dr. Sahil. Sahil છે કે Sahil છે? Sahil. બરાબર. I know મોના ઇંદા ચિતરવા ના પડે, અને he will give a talk on dealing with capsular complication in premium IOLs. Please go ahead. કદાચ આ બગડેલું હોય તો આ બાજુથી જ કરને. ચાલુ છે? પેલા મોહકને તકલીફ પડી ને. ભાઈ જતો ના રહેતો. હા. પછી ફોટો પાડવાનો છે.
No, 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 no. No. I'll just restart, sir. एक दो मिनट मैंने रीस्टार्ट पे रखा है. हाँ ना ना बस થઈ ગયો. Okay, sorry for that IT glitch. So this is we do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So this was a 54-year-old male, bilateral posterior subcapsular cataract. Nothing very complicated about the cataract, but at the end of lens removal, I could see this situation where there is an anterior capsular split which has occurred. So the rest of the 3/4 of the capsule is intact, and this part is open. The capsule is split from here. So once that occurs, once you notice this, now you want to make sure that this tear doesn't wrap around the posterior capsule and doesn't extend into a PCR. So to avoid that, the first thing that we need to do is to follow the principles that Dr. Bobby Osher has taught us, is closed chamber technique, which means never allow this chamber to shallow, because if you allow it to shallow, the lens iris diaphragm will move forward and this can easily extend to the posterior chamber. So even if you are not normally using dispersive viscoelastic, you must have that handy. And this is the eye where you want to inject dispersive viscoelastic, because cohesive can come out, so that the chamber doesn't shallow before you bring out your phaco probe. Now, in such eyes, I would definitely recommend bimanual IA, and you can notice I have reduced my flow rate to as low as 6 cc per minute. So it's aspiration flow rate which decides how quickly you are going to attract and catch anything. So whenever you want things to happen slowly, or whenever you want to time that, in case if you catch the capsule by mistake, you need time to reflux it, always use a low flow rate. So I've reduced my flow rate to 6 cc, and I'm swiping very, very slowly to make sure that the cortex is removed. Now the thing was, this patient is planned for a toric IOL. Okay, it's भैया यहाँ मूव हो रहा है, यहाँ स्टॉप हो गया है प्रेजेंटेशन. यहाँ स्लाइड फॉरवर्ड हो रही है मेरे में. Okay. So making sure that the cortex is removed completely from the area of the capsule. So I'm slowly but surely swiping and making sure that I bring it to the center before I actually step up on the vacuum. The other side was relatively easy. So at least one mission is accomplished, that I've been able to prevent this tear from extending to the posterior capsule. Now the second problem is, this patient was planned for a toric IOL, and the toric IOL, if you can notice, the placement axis is 112 degrees, which is exactly in the area of the anterior capsular split. So if it was a normal spherical IOL, it would have been easy. I would have oriented the haptic some other direction. But this is a single piece toric IOL, and the worry that I have is that if I put it in an area of an open capsule, first, will it come up and will it get captured? And second is, will this toric rotation, will this IOL remain stable, or will it rotate post-operatively? So we decided we'll take a chance and see how things go. We injected good cohesive viscoelastic, and making sure that the IOL unfolds slowly, and first I'm directing it away from the area of the anterior capsular split. And once I'm sure that the rest of the IOL, including the optic haptic junction, is in place, I'm rotating this IOL towards the area of my placement axis, which I'm actually visualizing through the Varion or the digital marking system through my microscope eyepiece. So I'm making sure that I align it to the area of the capsular split. Here you don't need to go actually behind the IOL to remove the viscoelastic, because there is already an open area. So just tapping on the IOL will make sure that the viscoelastic gets removed from behind also. And even in the end, make sure that the chamber doesn't collapse before you withdraw your irrigation. So with the irrigation in one hand, I'm making sure that the chamber remains well formed and the wound is secured. So the toric IOL is in place. The real test will be on the second day and in the follow-up, whether this IOL remains stable. And this is the patient more than 2 months follow-up now. The IOL has fortunately remained very stable, and it's behind the anterior capsular axis. There is some fibrous PCO that is developing, which may need YAG in the long run. So toric IOLs can be considered in selective cases of anterior capsular dehiscence, and stability is not an issue in the long run. This is a second case of a 27-year-old female, a unilateral posterior capsular cataract with a pre-existing defect. So if you can notice here, there is already a pre-existing defect with some lens matter you can already see in the anterior vitreous, which we could see clinically as well. Our preference is to do a femto delineation, which means we divide the lens not into chopping fragments, but into cylindrical lens division patterns, which will act as multiple hydro delineations, something that we described way back in 2015 in JCRS. Fortunately, having followed all the principles of cataract removal, we have ended now in this situation with a nice centered capsular axis. The lens matter is out, and there is no further extension of this pre-existing PCR that is there. So I have now a situation of a pre-existing defect with a plaque around it and some particles in the anterior vitreous phase. Now this patient had a very high astigmatism and was planned for a toric T7 diopter power. We had obviously counseled her that if things don't go well intraoperatively, we'll go with plan B, and that is put a 3-piece IOL in the sulcus. So we thought if we can salvage this posterior capsular tear and convert it into a posterior capsular rhexis, that still will act as a very strong margin for in-the-bag IOL implantation. And here you need all your dexterity and micro-incision rhexis forceps. So I'm using one side port, now I'm going from the other side port, so that I don't catch anything else except for the capsule, and so that I can direct my forces to not only create a posterior capsular rhexis, but also circumvent this plaque that is there, so that at the same time I can give a clear visual access to the patient. And slowly but surely, I'm winning, and we've been able to convert this PCR into a strong posterior capsulorhexis margin. Now there is already, like I said, some presence of particles in the anterior vitreous phase. We inject triamcinolone. Fortunately, there was no vitreous in the anterior chamber. So I'm just removing that little bit of muck that is there in the anterior vitreous phase, which was seen even clinically preoperatively. And this is the posterior capsulorhexis, and this is the anterior capsulorhexis. So now, even if we go ahead with in-the-bag IOL implantation, this capsulorhexis is not going to split, or the stability of the IOL is not going to be questioned. And this was a T7, and we are going ahead with in-the-bag IOL implantation and under cohesive viscoelastic. And then once that is done, we are aligning the IOL to its appropriate axis, which was vertical in this case. Again, re-inject triamcinolone and make sure that there is no vitreous disturbance even at the end, because of your manipulation, sometimes you may get vitreous disturbance even just with injecting triamcinolone. So confirm that and make sure that the eye remains stable. And this is the patient 2 weeks and now is followed up for more than a year. So toric IOLs can be considered even in selected cases of posterior capsular dehiscence, even if a PCCC can be fashioned. If not, then abandon the plan of in-the-bag IOL implantation. And finally, I think this is the most important slide for this conference for me, that is inviting all of you to Ahmedabad on behalf of Ahmedabad and Gujarat Ophthalmic Society. Thank you so much.
Thank you, Dr. Sail. Now I invite Dr. Path Rana to deliver lecture on the managing IOFB.
Good evening, everyone. So here I am going to present two cases of intraocular foreign body. Foreign body were of similar sizes, but the yes, it's there finally. So foreign bodies were of similar sizes, both young patient, young male, working in industry, and both the cases we had to have different kind of approach to remove the foreign body. So here I am going to show these cases. So this is a 24-year male, right eye trauma with iron particle while working on a lathing machine, and vision was PL, PR in all quadrants. So here is the pre-op picture. So there was a vitreous hemorrhage. We couldn't see where was the foreign body exactly, but it was confirmed in CT scan. And as a trauma surgeon, we have to we have to do pole-to-pole surgeries. So here I am starting first with lid suturing. So first lid suturing was done, and this gives us approximate idea from where the foreign body has entered, because this was a zone 3 trauma, because foreign body was entered quite posteriorly. So first I took the stay suture, and after taking the stay suture, I was able to see the entry wound. Usually what entry wound we see here, it's always larger than that. So when we are trying to suture this, so we always explore the wound first, and we see end-to-end margins of this wound first, and then only we start suturing. Because so many times we see a tiny entry point with a single or two sutures we complete it, and when we go inside the eye to do the surgery, then we see there's a leaking of fluid, and then we understand it was quite larger wound which we didn't see. So that's why first exploration is needed, and then suturing was started. Suturing is usually done in the center first and then in periphery, so we can see the proximities in that. And another thing to take care here is we have to do the cryo, because once it is crossing the pars plana, if it's behind, then cryo is must in all the cases. Because if we don't do cryo, there can be a severe PVR, and later on we can lose the eye. So that's why doing cryo is an important step here. So after finishing cryo, depending on the entry site, depending on the size of foreign body, we have to start the surgery. So many times it is like all the steps we have to improvise, like whatever we have decided, but we have to improvise during the surgery. So here I am starting with the vitrectomy. Foreign body, as we can see here, it was in anterior vitreous only. This is a metal particle. During the lathing, it came inside, and usually when this foreign bodies are coming, it comes very hot. So usually they are sterile. So in this kind of cases, infection is not a big issue. But the main issue here is the holding of this foreign body. I am going with pars plana route here. I am opening a wound here. Here, main problem happens in so many times. Like when we are seeing the foreign body inside the eye with the lens, we usually see it small. And accordingly, we try to not open bigger scleral opening. So what happens when we try to remove the foreign body, it gets stuck. Here I am removing all the conjunctiva, all tenons from the scleral opening. When I am seeing this foreign body inside, it is looking small. I'm pulling it up with a magnet, and when I'm trying to get it out, it usually entangles with choroid in surrounding. Here, as you can see, it is getting entangled in the choroid. So I'm trying to do the handshake. I'm trying to hold it with another max grip forceps from other side, but it is so smooth in all the boundaries, I'm not able to catch it. So many times this kind of foreign bodies like it is kind of quite irregular. Even we can't hold it with the multi-prong forceps also. So the main thing here to hold this kind of foreign body is like just get it with magnet and open a bigger scleral pocket there, so we can remove it easily. So finally, after multiple attempts, I put a PFCL below so it doesn't fall on the macula directly and doesn't injure the macula. So once after trying 2 or 3 times, I finally opened it, like I finally extended my scleral wound at pars plana, and now it is coming easily. As you can see here, just with the, I increase the pressure there, and just lower lip I am pressing there, and it is coming slowly out by itself. So here, and finally the suturing was done, and after suturing, I removed the PFCL, and whatever extra hemorrhage was there, that was also removed there. Sorry. I'll go with my next case. Here we try to save the lens in the first case, but in second case, here this is a corneal wound, and the foreign body has went through the cornea here, cornea, lens, and directly went inside. So we have to suture the cornea first here. As there's already anterior and posterior capsule was ruptured, so I have to sacrifice the lens here. Like so many times, this is one big question. This we hear it from so many cataract surgeons, that how do you do like whole lensectomy with cutter only? But cutter is our best friend for all the retina surgeons. So we are not kind of that comfortable with phacoprobes. So I try to finish my whole lensectomy with cutter only. And I feel when I am doing even capsulorhexis with cutter, that is also really good. So as Dr. Shell showed the posterior capsulorhexis with his forceps, I always try to do it with my cutter only. And I'm finding that also good in so many times. So here is the foreign body, what we are seeing there. It is already impacted on retina. So here vitrectomy is the core part here. We have to do a proper core vitrectomy. We have to loosen up the foreign body. Sometimes I try to leave some of the vitreous on posterior pole, that it will give me a cushion. So here I have taken the foreign body with multi-prong forceps. Here also you can see the similar kind of foreign body with rough edges, which is not coming that easily. Here I am trying to do the handshake, and I have taken the foreign body into the anterior chamber above the capsule when I am putting it. So here the handshake is done, and finally it was removed through the corneal root. So this was the clear corneal wound which I created, and finally I removed it. So many times what size of foreign body we are seeing inside the eye and what is there outside, it is kind of different. So it's always better to create a bigger wound and not to kind of rough the wound inside. So it's better for bigger wound only. So here I am doing the laser around the impacted area. So there should not be any RD starting from there. And finally, the fluid air exchange was done. And once after completing that, I have taken sutures on corneal wound also, and air was left inside. Yes, thank you.
Thank you, Dr. Panth. Excellent presentation. I invite Dr. Aditya Desai to deliver lecture on the smooth incision lenticular keratomelissis, new age in a refractive surgery. So from retina, now we are coming back to the cornea.
Okay, good evening, everyone. Since we have been going from anterior to posterior, we're back again on the most anterior part, which of the that is the refractive surgery. So there are a lot of refractive surgeries being developed over the years, starting with PRK, which is surface ablation, and over the years, flap-based, blade-free. The first key leg surgery, that is keratolenticular extraction, which was the SMILE procedure back in 2012. And now the new kid in the block, which is the silk procedure. So currently there are four major key legs platform. One is this Zeiss Visumax 800 Pro, the J&J Silk Elita platform, Atmos platform, and the Zimmer platform. So I'm going to share my experience with the J&J Elita Silk platform. So before going to the platform, I would like to tell you the difference between the two. That the key legs procedure is basically flapless. You don't have to create a flap. The lenticule which we make is via a femtosecond laser. Recovery is much faster. Dry eye is much less common compared to the flap-based surgeries. The corneal biomechanics is nicely managed with it. So the Elita platform can correct up the diopters up to half diopters to 12 diopters, and astigmatism from 0.25 to -6 diopters. It does not correct hypermetropia yet. So this is the Elita platform. As you can see, the big screen here is for the engineer or the optom, which helps to plan the treatment and give the basic treatment plan. The small screen is for the surgeon, which helps during the docking period for proper applanation and to see whether there is eye movements or not. The joystick obviously for the docking process, and the small prism, as you can see here, acts as a high resolution camera which helps in visualization because it does not have a microscope, so we are dependent on the screen itself, and also has a motion detection property. The few main points about this platform is that it has the shortest pulse duration, which is of 150 femtoseconds. So shortest pulse duration means that there is less tissue to no tissue disruption, and the surrounding tissues do not suffer from any thermal energy. The spot size, which I would say is the least in compared to all the platforms out there, which is less than 1 micron in space, as you can see, and it delivers a very high speed laser delivery for femtosecond, that is the 10 megahertz. So when we do the dissection for removal of lenticle, it's minimal to no dissection. The another key feature it has, it gives a laser cone or PI. When we attach it, the machine itself automatically every time detects the surface, knows its thickness and its orientation and tilt, and adjusts the laser accordingly. So we get repeatable and predictable laser delivery every time. The key feature of the Elita is that it is the only platform which gives a biconvex lenticule. All the other platforms give a plano-convex lenticule. So biconvex lenticule has a few advantages that when the anterior and posterior lenticular surface are matched, the Bowman layer is maintained, there is less corneal folds, nerve generation is maintained nicely, and the biomechanical strength is nice. It also gives a transition zone, as you can see, so which is not compromise the optical zone, which separates the both, and a non-refractive which helps to go inside and take the lenticule out easily. It also has another feature which we call it as the radial scan pattern, and it scans the anterior and posterior, that it cuts the anterior and posterior lenticule twice compared to the other platforms which have a circular motion. The docking is also very nice, and from my experience, till now, since June I've started, it's almost 800 eyes. I would say only 3 patients have suffered docking due to their anxiety, and they just moved the eye in the last position. Otherwise, relatively, the docking is so good; it is absolutely painless. No patient has, as such, complained about the pain while docking. So now I'll just share a video of the procedure. As you can see, this is the machine, the platform. When the laser cone, as you can see, is attach the prism to the prism, and after applying the speculum, we just look at the treatment plan on the big screen. When the treatment plan is approved, we just scan the cone. Like I previously told you, this scanning helps every time that the prism delivers a perfect and a nice laser delivery and repeatability and predictability. I always mark the 0 and 180 on the slit lamp. People use toric marker as well because it for the compensation of cyclotorsion. Because when we dock, because it is a 2-hand docking system, that a vacuum ring holds the eye and the machine is docked slowly with the prism, and they applanate the cornea. As you will see now, it is slowly applanating the cornea on the ring which I have placed. Once the applanation is okay, as you can see, the tear meniscus spreading, and it's beyond the 10 mm wide zone. We just lock the vacuum so that we can, and after locking the vacuum, either the opton or the doctor can manage the cyclotorsion which or dilatation which has occurred, or the centration the doctor can manage from his small screen which is there. Once everything is fine, we just start the delivery process with a foot paddle. As you can see, first the anterior surface, and then the posterior and the non-applanated, the non-refractive area gets separated, and then the 2 to 3 mm laser entry point. I prefer 2.5. Once, as you can see, a nice OBL and nice lenticule is made, we shift the patient to the other OT under a microscope and start with the lenticule removal process. Once the entry point is found, as you can see, I look for the anterior surface. Knowing the anterior and the posterior is by knowing the OBL. If the instrument here, you can see I'm in the anterior plane, the OBL is not there, that means you're in the anterior plane, and in the posterior you can see the above the instrument there is OBL, that is the opaque bubble layer. As you can see, the dissection was quite smooth, and the lenticule was removed very easily and very smoothly, just like silk. And after checking this lenticule is properly dissected, I just iron the cornea with the cannula and also with the spud, just for extra precaution that there are no bomb and folds for the surgery. Another technique which is now more popular is the lenticulo-capsular After the entry point, just use a micro dissection forceps. I go anti-clockwise and just remove the lenticle smoothly with one swipe. And just open it and check it properly whether the lenticule is perfectly dissected. And yeah, that's about it. So, in my experience with Silk Alita platform, doing 800 eyes till now since June, I would say patient gets about 20 by 20 vision, or 89% of them get 20 by 20 vision or more on post-op day 1. But by 1 week to 15 days, most of them get 20 by 20 or more vision. And I have received only around 300 to 325 eyes, to be more specific, on a 3-month follow-up, where almost 99% of them have got 20 by 20 vision or more. Thank you so much.
This brings an end to the session. Can we all stand in front of the podium for a photograph? Thank you.
One important announcement: because of lack of communication here, we are not able to get the memento for each speaker, so we have to collect from the 5th floor. Memento for each speaker.
તમે બધાને લઈ આવીને ત્યાં નહીં આપો?
Yes, you have to sign.
તમે તો જોઈએ જ.